We'll start a minute early and steal a little bit of extra time. Thank you all for coming. Good morning. Thank you to the SAEM Ethics Committee for their sponsorship. We're going to be talking today about the accidental ethicist and clinical ethics and ethical education for the non-ethicist. Our distinguished presenters, relevant disclosures, some brief objectives. So we're going to talk a little bit, review some frameworks to think about how we can define and navigate ethical issues. We're going to use some, we'll say, inspired by true event clinical cases to try to think through how we might apply those ethical issues and frameworks. And then lastly, think about some strategies to better employ medical education with respect to ethics. First, the why. Thank you to some sort of AI generative art for creating this image for us. So ethical issues are common in the emergency department. And for anyone who works in a busy shop, you're hard pressed to go more than a shift or two at a time without coming across at least some sort of ethical conundrum. Unfortunately, because of the nature of our work, the time-sensitive nature of emergency medicine, we don't often have access to the conventional avenues like, say, an ethics committee consult. That isn't often a feasible or viable approach for us. And since we're seeing this stuff, and many of us here also have some responsibility as educators for medical students or residents, fellows, having some familiarity with ethical issues, how to navigate them in real time on shift, and how to educate about them are important for our practice. So I want to talk about a couple of common frameworks that we can use to think about ethics and bioethics in particular. One probably more familiar, one maybe a little bit less so. The first is principlism. This is going to be familiar to most of the people in this room. Autonomy, non-maleficence, beneficence, and justice. To any formally trained ethicists, I'm going to apologize for my very, very brief definitions of these that are probably going to be a little bit lacking. Autonomy is relatively straightforward. Non-maleficence is functionally do no harm. Beneficence is do good. And then justice, thinking about fairness and equity in the way that we deliver care. A little bit less common a framework would be something like the 4-box method. This can be really nice to think through actual pragmatic thought processes on how to navigate ethical issues in the emergency department. There are 4 components to this as well: medical indications, patient preferences, the quality of life involved, and then contextual features. So medical indications, some nuance there might be stuff like, is this acute or chronic issue? Is this life-threatening pathology? How invasive is the intervention that we're considering? Things like that. Patient preferences is obviously going to be a little bit more straightforward. Quality of life, as far as what role does our care, treatment, diagnostic testing have on the patient's quality of life? And then contextual features is everything else. So is this part of a research study? Is this an incarcerated individual? Things like that. It's going to be helpful to think about almost scales that we're putting weights on to kind of navigate the thorniness of I have a problem in front of me, and just defining, hey, this is an issue of autonomy, sometimes only gets you so far. The 4-box method is maybe a little bit more helpful actually making clinical decisions. So I'm going to try to apply this very briefly to a case. Again, this is AI art, so relax, okay? And then I'm going to turn it over to my colleagues. I want for you to imagine a case where a patient comes into your emergency department and he's incarcerated. He comes from jail or prison and he has taken self-injurious behavior. He's cut himself and provoked a bunch of bleeding. For my colleagues, they may vaguely recognize this sort of case, okay? The patient presents with significant bleeding. He says, I'm not trying to hurt myself. I'm not trying to kill myself. I just hate being in jail, and this is the only thing that I can come up with that gets me out of jail. He seems to have excellent insight. There doesn't seem to be anything else that is impairing his judgment, and he wants no treatment, no testing, no blood work, no blood transfusions. But there's a lot of blood. Are we going to do anything about that? There's some complicated issues at play here. Just by show of hands, who here would take steps to, say, transfuse if you thought it was indicated, even if the patient preferred not to? Okay, mixed bag, but it's complicated, and it seems most are trending towards no, with maybe a couple of yeses. I think it's okay to acknowledge this is gray stuff. And how do we think through this decision can be helpful using stuff like that 4-box method or defining the ethical issues in play. And if you have a trainee on shift with you, naming those ethical issues so that they understand the way that we're thinking issues of autonomy. Obviously, for an incarcerated patient, that's going to be a little bit more nebulous than someone else just walking in off the street. Thinking about justice, medical resource utilization, if this person comes back, and indeed in this hypothetical case, they did, this became a recurring phenomenon. Navigating this stuff can be really challenging, and thinking through how do we actually put words to the ethical issues at play can help us make a good and just decision. All right, and with that, I'm going to turn it over to my colleague, Dr. Paxton.
Okay, James Paxton here, Wayne State. And what we're doing in this part of the show is, and sorry that this is like a micro didactic, so you guys are only getting 20 minutes, but we wanted to expose you to a couple cases. And again, these are kind of taken from the real world, and just explain maybe how some of these principles might apply to these cases. So this is case number 2, and this is Mr. J.M. He's a 68-year-old male who's presenting to your department with chest pain complaint. He's kind of pale looking, but he's alert, seems sober, complaining of chest pressure, classic crushing chest pressure. You get an EKG, it looks like this, and you make a clinical diagnosis. This guy's probably having a STEMI. That's what you decide. He's in the department for a few minutes. You do some tests. You do some, specifically a troponin. It's 830. You interpret that as elevated. You go to the patient and you say, "Sir, I believe you're having a heart attack, and at our institution, we recommend a catheterization for you." And you explain what that is and what the risks and benefits are, and the patient politely says, "No, that's okay, I'm good." And you explain, well, you could have permanent damage to your heart, you could be in heart failure, you could die. Patient still says, "Well, that's your opinion, but I feel better now, and I think I'll be fine, so I'm gonna go ahead and leave." We all have variations on this case, hopefully not that extreme, but how do you manage that, right? So this is where you get into like against medical advice kind of discussions and things, and you're documenting that very well, of course. But there are the ethical issues involved too, right? So he mentioned principlism with the 4 main concepts. I think in this case, autonomy is number 1, right? You're respecting that person's ability to decide for themselves, even if you disagree with the decision. And so you also, however, have beneficence in that we rapidly assessed this patient. We were doing a proactive assessment for the patient. Non-maleficence, in that we didn't just throw this guy in the pile and say, well, you know, chest pain, that's great. We'll get your EKG when we get to it. That would be a way of hurting someone, right? If you have clinical suspicion they're having a heart attack, you need to evaluate them. Not doing that would be causing damage, doing harm. And then, of course, you have a lot of other issues that come into play. In this case, the patient was discharged against medical advice, came back an hour later, more chest pressure. Now he agrees to the cath. They found an occlusion, and he got hospitalized, did okay. New diagnosis of heart failure, but at the end of the day, whether we agree with the decision made by the patient or not, we need to respect their ability to make those decisions. Case number 3, also relating to autonomy. This is Mrs. J.M. She's 78 years old, and she has metastatic cancer. She comes to your department complaining of shortness of breath, just feeling tired. You do a workup for her. She has pneumonia. More than that, she has an elevated lactate. She looks septic. Her blood pressure starts to slide. You have a conversation with her, and you know her medical history. You know that she's metastatic cancer. She says, "I don't want anything done. No aggressive measures." She asks to be DNR, DNI. You have a full discussion about that while she's alert and talking to you. She's in your department. She's still going to be admitted. She doesn't want to be intubated. She doesn't want a central line, but she's willing to be admitted and receive antibiotics, fluids, and so forth. While she's in your department, she starts to decompensate. Blood pressure goes down. The patient's now confused. By now, the family showed up, and specifically one of the sons is very angry and says to you, "My mother would never want you to just ignore her like this. She wants everything done, and she told me that." Now you have a problem because you spoke to the patient, and she told you, and she was alert and oriented times 4, not drunk, and told you, "I don't want those things." But now the son says that she would and that she did. So you have to make a decision, right? You're the one who's the captain of the ship. What are you going to do? At the end of the day, I think whatever the family believes, it's still the patient's autonomy that you're respecting, right? And if you know for a fact the patient doesn't want that intervention, then ethically, I think you respect their autonomy and you do as they would direct. But there are other concerns as well, right? And so we have to be sensitive in these situations. We don't want to do harm. We do want to do good for the patients, but we have to respect the families and their decisions. So I think autonomy is certainly a key concept here, but sometimes you can bring in other people to help you with that. So you can bring a patient advocate, you can bring a chaplain, whoever at your institution is able to assist in these situations might be able to help you explain to the family that what you're doing is really what mom wanted. And you're not doing this out of neglect or apathy. You're doing it because she asked for this, and that's what she wants. Okay? So and in this case, the patient did receive medications through peripheral line. She was admitted. She died the next day of septic shock. And so at the end of the day, the family were aware of the reasoning. The son never really agreed, but ultimately the rest of the family came around and they had a good discussion about goals of care and so on. So with that, I'll pass it off for case 4.
Hi, everyone. So not to kind of rehash, but I kind of like my idea of spaced repetition, even though the space is not very big in this very short talk. But this case involves another prisoner, but it comes a little bit with a different twist. A gentleman that's been to the emergency department about 6 times in the past month. He's on a hunger strike. He refuses to eat. He has no interest in eating. He believes he's protesting the inhumane conditions at the prison that he's staying in. He doesn't believe it's right, and he is taking a stand that he no longer wants to eat anything. He's amenable to PO fluids and IV hydration, and that's it. You do routine workup for him. You notice that there is a bit of a central gestalt that kind of the staff is kind of frustrated with. The medicine staff is kind of frustrated. This is the 6th time the guy's been here in a month. He never wants to eat. Sometimes an AKI, sometimes he doesn't. Sometimes he's hypokalemic, sometimes he isn't. He gets seen, he gets admitted, he gets discharged the next day. There's definitely a sense of like, what are we going to do for this guy? I know you guys have all probably felt that kind of feeling that you can get from that pushback, not even if it's explicit, but implicit from your colleagues in the hospital. You get a set of labs. He's hypokalemic, 3.1. Otherwise, a touch of an AKI. You notice his albumin's downtrending, and maybe a little bit of third spacing. He's getting some swelling in his ankles. You talk to him about it. You're pretty objective. He says, "Thank you, doctor. I appreciate it, but I know what I'm doing, and I don't want to eat anything." From ethical dilemmas, I really like the idea of just being very deliberate, and I'm going to talk a little bit more when we incorporate it in medical education, but just going step by step. Let's apply autonomy to this patient. He's alert, he's oriented, he's made a conscious decision. He no longer wants to eat. He has something in his mind that he's very focused on. And there's not really too much wiggle room in his decision-making at this time. And I don't know if really the emergency department's had enough time to decompress and really have this kind of conversation with him. Do you hold it over his head? Do you force him against his will, even though he's kind of verbalizing exactly why? I don't know if that's truly fair. So then you go to the next step. Let's apply non-malfeasance, do no harm. He's got some electrolyte abnormalities. He's amenable to IV fluids. I don't see what's the issue with just treating it as needed and trending his repeat metabolic panels as needed. Nothing crazy. We're not going to do any harm. We're not going to give him excessive fluid. We could discuss maybe intravenous albumin, but I think that might be beyond the scope of this lecture. And then we go to the next step, beneficence. What is right for the patient? The right is to probably just treat him as you would anyone else. If he was NPO for another reason, say he was G2 dependent, G2 was malfunctioning, and he had these abnormalities, would it be any different? Probably not. So it really shouldn't bias your medical decision-making. I think that's part of this intentionality with going through each of the steps. You can kind of avoid some of that because you're like, hey, I'm thinking about this, I'm thinking about that, I'm thinking about that. And then finally, justice, equitable care for this guy would probably admit him. He has an admittable, issue, AKI, electrolyte abnormality. So no real reason not to just treat him like anybody else, even though you might get might be an inertia through one direction of just, we're not going to do anything to this guy. Might as well just send him back to the prison because he's wasting everybody's time. They may not say it out loud, or T might not say it out loud, but you can kind of feel it. But the way you can kind of push back is just be very intentional and deliberate, especially when you document. I think it's another big thing to bring to learners. It's just like, hey, if you're thinking it the same way you would think about a heart score or a primary survey in trauma, just kind of incorporate it into their mindset. So they know moving forward, hey, okay, let me just step out and use this framework to really think about this patient in that perspective. Then we can go into the cardiovascular, pulmonary, et cetera. So busy slide, but essentially that's what I kind of want to get into is really like the best ways to kind of frame this. I would say this is a bit of a case-based discussion, and it's no different than something you could run at a conference, every Wednesday conference, just spend a half hour doing like some of these cases and just running by the learners and asking them very targetedly, how would you do this step by step? Tell me about how you would incorporate the ethics into this scenario. Simulation is another great avenue for that. basically kind of run the same thing. You can get standardized learners, or you could, just run the case yourselves, resources permitting. And I think it's a good way to just have that like talk back, recall this information, and it's a good way to just kind of practice these habits. So when they get on shift, it's pretty natural for them. I know we're kind of short on time, but I guess incorporating into bedside teaching is not really that much different. But I think the biggest thing is what Dr. McGregor kind of alluded to, which is be very intentional and say what you're thinking out loud. A lot of times, we can fall into the trap of just like, guess what I'm thinking? What do you think about this patient? Oh, he's got this knee pain, he's got a foot drop. Tell me what you're thinking. And, they're trying to get answers, but they may not know the exact things that you're looking for. So be intentional. Say, hey, I'm thinking about this in this scenario. You guys ever heard about this? Have you thought about principalism? You've heard of principalism before? Why don't we talk about it? Why don't you look it up and then kind of tell me about it? And it's a way to just kind of cement that into their brains and their medical decision-making moving forward. And then you could even comment like, hey, I'm going to document this because this is a complex case. He's on a hunger strike, but I really want to be very intentional and explain to myself, whoever's reading this note, whether that be colleagues or anything medical legal, of just like why I'm doing the things that I'm doing. And of course, just like a good, I guess, analogy is like, aortic dissection. If you don't think about it, you won't do anything about it. So with that, I'll end. And if you guys have any questions, happy to answer them. You guys have any questions?
I was curious, so going back to the forecast, I was curious about the metric of the quality of life. I think I thought about quality of life a lot of times thinking about disability justice and how we're trying to move away from quality of life in order to not bias ourselves. Because quality of life is a metric that could create bias because as a clinician, I'm unable to assume or know what quality of life looks like. So I'm curious about how you use quality of life in the context of medical.
So in the interest of a short talk, I try to keep the words pretty Spartan, but there can be a lot that's incorporated into quality of life as a component of the four-box method. So you could imagine something like a patient who has a debilitating lower intestinal occlusion, and the intervention is someone who's normally neurocognitively intact, and the intervention that we're thinking about is thrombectomy, versus a person who has a skin wound on their leg and a patient who's ANO times 0 bedded down in a nursing home. The difference in how we might think a calculus of that decision making does in part rely upon the quality of life. So it's not us necessarily making a determination about what is the patient's quality of life as much as what role does this test, does this treatment, does this diagnosis have on the patient's potential quality of life. With that sort of addresses your question.
It's also important to recognize that the quality of life question is the patient's perception of quality of life. It should never be, sometimes we default to that, but the provider's perception, right? And many patients who have severe handicaps, severe disabilities, severe medical conditions have a high quality of life in their estimation, and that should be the metric that you're looking at. Hopefully not whether I would personally want to be in that situation or not think it's a good thing.
Yeah. So anything and everything is the long and short of it. You can imagine a scenario where we're thinking about giving someone IV fluids against the backdrop of a national IV fluid shortage, and the way that that might inform your decision making. That would be a contextual feature. How we think about something in the setting of a COVID pandemic might be different than another time course, and that too would be a contextual feature. If it's a test or treatment that's part of a randomized controlled trial, and we're thinking about stuff beyond just the care of the patient in front of you, but something else entirely, now that we're getting the research out there, we're thinking about downstream effects of the knowledge that we might acquire from this. Those would be things that you might sort of incorporate into contextual features. But we can talk about contextual features for hours, but that would potentially be a goal.
And also just piggyback that time is probably the biggest one for me. The emergency department, as far as contextual features, is like time to see this patient, time to make this disposition, time to admit, time to see the other 5 or 6 critically ill patients I have. And I think some of that context is important for the patient, but it's also important for your own framing about how I'm running an ED, how am I running my own shop if I have part of this is kind of offloading and using some of this framework to kind of help me guide this decision making so I can do it faster.
And it's not an absolute that 2 or 4 cases involved incarcerated patients. That's a contextual feature, but a really important one that's going to play a huge role in how we think about how to prevent hearing something.
I was wondering, it seems like oftentimes you come up with a mutually agreeable plan, like with consultation, it might be kind of supportive here, et cetera. And then you call the admitting position and get a lot of pushback because we're like, well, not doing anything. And so I think that is a very challenging point in anybody getting advice for those conversations and how to, somebody that, because you're truly being ambition that maybe it's like trending right to me to the support here.
I could offer general advice of being an advocate for your patient and taking that position with other providers who emphasizing the importance of what you're doing for the patient. And we can't argue if there's policies and regulations that get past those, but I think in our role as a provider and a clinician, we can advocate for our patients and what we feel obviously is best for them. This is why we're doing it. And they may say, well, that's not important, and we have to emphasize the importance to the patient, bring it back to the patient, which is harder to argue, I think, from their perspective. Because they don't know the patient either, they never met them, they don't know what they want to do. Other questions? Great, thank you so much.
Thank you all.
Thank you guys.